Good afternoon, or good morning to those of you who are watching via webcast. My name is Susan Poland. I'm the Associate Executive Director for Public Affairs and Advocacy at the American Public Health Association, and I am so pleased to welcome you to the National Public Health Week Kickoff Forum, Healthiest Nation 2030, Raising the Grade, and to begin the celebration of National Public Health Week with you. As some of you know, this is the 20th anniversary of National Public Health Week, officially proclaimed by President Clinton in 1995, and we are awaiting, truly, momentarily, the presidential proclamation from President Obama this year to celebrate the 20th anniversary and all the good work that you and the rest of the public health community do. So thank you for being here. Thank you for all that you do. I want to talk a little bit about some of the background of National Public Health Week and the American Public Health Association, and then it will be my honor to introduce our keynote speaker. The Healthiest Nation Kickoff Forum and National Public Health Week is really the beginning of APHA's 15-year challenge of creating the healthiest nation in one generation. This is a daunting and exciting goal, and we are doing this in partnership with all of the organizations that are part of National Public Health Week and all of the organizations and individuals who are interested in participating. It is something that we recognize we cannot do without involvement of everybody in the community. And it's one of the reasons why an important piece of this National Public Health Week is the pledge that we've put forward. And we hope that all of you have signed on and all of you tell all of your friends and family to sign on. And the pledge is really very much about what works for me and how are we going to do this together, because you as an individual have the responsibility and the opportunity to be healthy, but you as an individual can't do it alone. So we have to work together as part of a community to create the healthiest nation. There are some things that we cannot fix alone, and that's really what we're going to try and focus on over the course of the next 15 years. This is the kickoff event, and this is always very exciting. And for those of you who are watching, we are also following, we hope that you will follow this on Twitter. You will live feed those of you who are sitting here and want to participate in the Twitter chat. We'd love that, using the hashtag NPHW. And at the end, for those of you who are watching on the webcast, please feel free to send us questions or throughout using that hashtag NPHW. In addition, we'll be having a Twitter chat that's a more formal process on Wednesday at 2 p.m. Eastern, and so we hope that you'll all participate in that. You can become part of the truly thousands of people who participate in the Twitter chat, and it really does make for a great conversation. And it's a great way to hear from and learn about public health from people ranging from Dr. Richard Besser, who is with ABC News, to Dr. Tom Frieden, who's the head of the Centers for Disease Control, as well as our Surgeon General. So we hope that you all will participate in that. We have a contest going on for National Public Health Week, which is also kind of a fun thing to do, because really, as I said, we can change by ourselves, and we can change as part of a community. So please send us pictures of how you're changing and what you're doing to create the healthiest nation and what you're doing better. You can submit a video, you can submit a meme, you can submit whatever you think is appropriate using social media, so we hope you will do that. Finally, we have a whole array of other events around the country. And if you go to the nphw.org, you can find out what's going on in your community and find out what else is happening and how we're hoping to create the healthiest nation. With that, it is really my pleasure to introduce our keynote speaker, as soon as technology catches up with me. Dr. Gail Christopher is the Vice President for Policy and the Senior Advisor at the W.K. Kellogg Foundation. Dr. Christopher is involved in the President's Cabinet in this role, helping to determine the overall direction of the foundation. She's a nationally recognized leader in health policy with particular expertise and experience in the issues related to social determinants of health, health inequities, and public policy issues of concern to our nation's future. Her distinguished career and contributions to public service were honored in 1996 when she was elected as a Fellow of the National Academy of Public Administration. In 2011, she was awarded a Change Agent Award by the Schott Foundation for Public Education, and she currently serves as the President of the Board for the Trust for America's Health. So please welcome, join me in welcoming Dr. Christopher.
Good afternoon. It's a pleasure to be here. It's really an honor to have been invited to share thoughts with you this afternoon. And what an ambitious goal, to make our country the healthiest nation. Now, some things require a stretch, and some things require a leap. For us to become the healthiest nation, we all know the data is going to require more than a stretch. And so I want to have a frank conversation with you today about the role of public health in getting us there. Just to establish that as an intention is a very, very powerful breakthrough admission. Breakthrough in the sense that it is going to override the dominant belief in the public that we are the healthiest nation. The average person subscribes to the theory that America has the best health care, and therefore we are the healthiest nation. And we've seen the data, and we know globally we are far from that. And I concur with Dr. Stephen Wolfe, who suggests in a commentary in the Journal of the American Medical Association that it is our policies that are not specifically health policies that are making the greatest contribution to our poor standing globally, the greatest contribution to our less than ideal ranking in terms of being a healthy nation. Dr. Wolfe has been researching this for many years, and he reminds us that when we don't have effective education systems, and we are not educating all of our children equally, we are contributing to poor health outcomes. When we don't have an equitable opportunity for employment for all of our nation's people, when we don't have a safety net that undergirds people during those periods of lack of employment, when we continue to make policy decisions that lead to instability and insecurity, particularly economic insecurity, we are contributing to poor health outcomes. Now, this is not news. When we don't have affordable housing, we're contributing to poor health outcomes. So the Public Health Association and the work of the public health community moving forward to achieve this ambitious goal requires standing up for policies that are not always directly health policies or even health care policies. We have a huge national constituency in terms of public health, and this constituency must be mobilized to stand up for those policies that are necessary to assure well-being. Now, I bring you greetings on behalf of the W.K. Kellogg Foundation, on behalf of our president and our executive team that are hard at work back there in Michigan. But our mission, when our founder left his fortune to us, he said, do what you will with the money, so long as it helps children, particularly vulnerable children. And about 8 years ago, we took a look at the data and we recognized that most of the children born in this country now and in the immediate future are children of color. And most of those children are growing up in either low-income or impoverished communities and neighborhoods. And so we asked ourselves, what is the work that needs to be done to propel those vulnerable children to success? We honed in on a social determinants framework, focusing on education, focusing on access to food and quality health and well-being within their communities, and family economic security. But we also understood that it was time to develop a very explicit agenda about addressing the legacy of racism that helped to shape the culture of our country. I will share with you some of the insights that we've gleaned from funding many, many groups around this country who dare to have the courage to thoughtfully and carefully and reflectively tackle this challenge. But in general, the philanthropic world has moved this concept of social determinants of well-being forward, and they are embracing it. the Robert Wood Johnson Foundation's Creating a Culture of Health initiative is one powerful example. The California Endowment's Building Healthy Communities. Place-based work has been the hallmark of many investments for major national foundations for a very long time. I always tell people there's some advantages to growing older. None of them are physical. But you do live long enough to see ideas go from a nascent state to actually being embraced and actually becoming the norm almost. So as a partner with public health, the philanthropic world is right there with you in terms of understanding that we have to create the conditions that allow for health and well-being. And that's one way to define public health. It is what we as a society do collectively to assure the conditions in which people can be healthy. And that's why I believe the Robert Wood Johnson Foundation's focus on the culture of health is a breakthrough framing for us. Because, you know, when you talk about social determinants of health and you talk about life course perspective, you know, it's wonk speak, right? And the average person sort of glazes over. And so we need ways to communicate and galvanize and move people that folks can understand. Now, Gandhi once said that the culture of a nation rests in the hearts and the souls of its people. Our work on racial equity would agree with Mahatma Gandhi, but we'd also modify that and say that the culture of a nation rests in the hearts and souls and minds of the people. In this age of the brain and brain science and neuroscience, it's very clear to us that the legacy of a belief in a hierarchy of human value, or racism, and all the other isms that deny opportunity and discriminate based on physical characteristics, that this hierarchical belief system has been such a part of the DNA of our country for so many centuries. We've had episodic moments of protest against it. We've had a civil rights movement. We had a civil war. We had a Reconstruction period after the Civil War. But these episodic spikes in protests are then followed by periods where things return to the status quo. So the issue today of the legacy of the belief in human hierarchy is not the same as it was in the 20th century. The issue today has as much to do with unconscious bias as it does conscious bias. And neuroscience is helping us to understand how the need to categorize and create schema is just a part of being human. It's what we do. I don't look at that chair and say, oh, that's a back and a seat and 4 arms, 4 legs and 2 arms. Aha, that's a chair. My brain has categorized that image to know when I see it, and I have an automatic assessment that that's a chair and I can sit in it. We've been bombarded for so long with stereotypical projections and impressions about the other and about difference that we have done the same type of categorization and created the same types of schema about people. And those responses become automatic. So this work on unconscious bias is a necessary component to getting us to be the healthiest nation. Now, what do I mean by that? I mean that exposure to discrimination and denied opportunity or inequity in opportunity based on residential segregation and other factors or patterns of disinvestment, those are critical components or barriers to realizing our dream of being a healthy nation. We simply have to put this work right into the heart of our agenda for change. Every person that can make a life and death decision about others should know where they are vulnerable for being biased, and they should have the tools and the resources at their disposal not to act on those biases so easily. Now, we know that the most lethal decisions are made by law enforcement, and in some cases by healthcare. And so those are two primary communities for intervening to overcome these automatic and deeply entrenched biases. And that isn't going to happen without investments. It isn't going to happen without acknowledging that it is part of our work. And so when we talk about, you hear these lighthearted, they're not lighthearted, that's not appropriate, but you do hear these references to, we need as a nation to have a conversation about race. And a lot of us glaze over and say, I don't want to talk about race. Or we had that conversation. What I'm suggesting to you is that today's science is showing us that it's more than a conversation. It's assessment, it's recognition, it's accessing the tools and resources within communities to help us overcome the legacy of an entrenched belief in a hierarchy of human value. Now, public health of the 20th century accomplished so many things. Indeed, the general public doesn't really understand all that public health did to make us the nation we are today. It's a funny thing, when something becomes ubiquitous, we just don't see it. I'm reminded of the struggle we've had and continue to have on the issue of lead in the air and now, more importantly, in the drinking water systems in our nation's schools and communities. But lead was such a ubiquitous element in our culture that it took a concerted effort to identify it and get policy changes and ultimately get solutions to the problem. We're not finished with that. But I equate this idea of bias in our society as something like the lead problem. It is ubiquitous. And as a consequence, we often don't even see it. And we don't see it, but we certainly see its outcomes. So the public health field has used the technology and the knowledge of its era to make major, major victories. It has also used the population's values and concerns. Now, the general public right now was mobilized to be very concerned about public health when they were terribly frightened of the possibility of the Ebola virus being in our society. We heard more about public health in that brief window than probably we have heard in the last decade. And yet, gun violence in this country kills at least 85 people a day. And we are not up in arms about gun violence. One of the things we have to do is do a better job of framing for the public the real threats that we face in terms of our well-being. And we, a violent nation, cannot be a healthy nation. This idea that we are entertained by violence, that mainstream television and cable television and all the other televisions and the motion picture industry, wherever we turn, we see violence as a form of entertainment. We've created a culture of violence. And then the issues of gun safety, the issues of the proliferation of guns in the hands of children. This is a public health issue. And I know there's tension around that, and some of us dare not speak it. But I just came from Chicago last week. And that's a community where 25 and 30 people die on a weekend from gun violence. So something has to be done about that. And the disparate numbers of children of color who are dying, this is part of us becoming the healthiest nation. So how do we get to be a culture that really values health? I think we have to redefine what we mean by health. I think we have to focus people's attention on the miracle of the human body and its capacities to be healthy. We have to get people to understand that health is truly an option. And that's a different kind of literacy. It's not necessarily only medical literacy. It's literacy about health and the human body. It's literacy about how stress, allostatic load, and continuous exposures wear at the body's capacity to be resilient and to be healthy. Now, the knowledge of this century, all this amazing technology, but also the exploration of the human genome and epigenetics. I think epigenetics is the most exciting frontier because finally we're going to be able to understand not only that stress and disadvantage and discrimination and inequities predispose us to being ill, but we're going to be able to better understand the physiological pathways as to how those burdens actually tax our systems and make us more likely to be ill. And David Williams and Jack Shonkoff at Harvard are doing some amazing work on identifying the biomarkers that reflect increased allostatic load. And there's so much work going on now around childhood adversity and toxic stress and how that predisposes to a lifelong vulnerability to chronic disease. But what I'm most excited about in Dr. Williams' work is he's showing that even if you have too much exposure to adversity in childhood, if you don't grow up and have to live in communities where the opportunities are still unequal, you don't have to manifest the chronic disease vulnerabilities that were predicted based on your childhood adversity exposures. So, in conclusion, I would be remiss if I didn't say we will not become the healthiest nation without addressing the legacy of a belief in a hierarchy of human value, or that's my polite way of saying racism, and the other isms that divide us. That is part of our work, but there is a science and there is an art to that work, and we must integrate that into our priorities in terms of public health. You know, perhaps the greatest mind of the 20th century, he's acknowledged as that anyway, was Albert Einstein. And of all the hundreds of books that have been written about Einstein, only one of them chronicles his commitment to overcoming racism. I highly recommend that book. He was friends with Du Bois, he was friends with Paul Robeson, he stood behind the NAACP. He was committed to overcoming, and I'm going to end with a quote from him. In 1946, he said, "I do not believe there is a way in which this deeply entrenched evil can be quickly healed. But until this goal is reached, there is no greater satisfaction for a just and well-meaning person than the knowledge that he has done his best in an effort in this cause. So our greatest mind of the 20th century reminded us of the importance of this task. And I was invited here today, I'm sure, because they knew I would remind us that this is part of becoming the healthiest nation. Thank you. I believe I have time for a couple of questions or comments or reactions. Yes.
Thank you for those really inspiring and focusing remarks. We talk about this as a social movement, and what I'm wondering is that if you can comment, from the civil rights movement, you were talking about history as to whether you think we can actually make a sustainable social movement take place in order to do this.
Young people have led all of our movements, and they are leading this one. Now, it happens that these tragedies have brought to light the pattern of the use of lethal force against unarmed young people of color. And so you have a moment of organization and activism on the part of young people today that I haven't seen before. But not just young people, the people marching in the streets of New York were of all races, all ages, all socioeconomic groups, and they were saying this is not acceptable, this is wrong. But like any other movement, you probably had a decade of activities going on quietly before things burst to the surface. And I think that's what's happened here. But what we have to do is connect the dots. There's the movement for environmental justice and sustainability. There should be a movement for optimal health conditions in communities. There's a movement for racial and justice. There's a movement to overcome these vast economic divides that we're expanding toward economic equality. But they all center around creating conditions in which people can live and realize their dreams of health, well-being, and perhaps even prosperity. So we have to leverage today's information technology, and it's here at levels it's never existed before, I believe, to pull us together and coalesce around this goal. And I believe there's a critical leadership role for the public health community, because ultimately, these are matters of life and death. And they're also huge matters of economic investment and, unfortunately, disinvestment. But thank you. So I'm optimistic. I used to say to people, this won't happen in my lifetime. And the young people challenged me, and they said, why do you say that? And I said, well, I know these things take time. And they said, unacceptable. So they formed their own organization, which is called Within Our Lifetime. And their commitment as young people in their 20s and 30s is to end racism within their lifetimes. You can actually go to their website and you can take the unconscious bias tests, implicit bias tests, and they are doing very good work. So I am optimistic, but it will be the young people that lead us for sure. Do we have time for one more question or comment? Now don't be shy. Yes. Could you stand and they'll bring you a mic?
Hi, thank you so much. That was a wonderful talk. We have to work through, if we want to make a living, through organizations.
Yes.
And I was just wondering if you have any thoughts about organizations here in Washington that are thinking the way you are and doing the kind of work that you would want.
Now, if you hadn't added here in Washington, I had a whole list of organizations.
Okay, go for it.
No, just kidding. There are many organizations that are working on these issues, and I would encourage you to visit our website at the W.K. Kellogg Foundation. We also fund all the major civil rights organizations, and we have asked them to work together and to collaborate. And because our approach to this is not, it's about the belief system. So we work with Native American, with Asian American, Pacific Islander, Native Hawaiian, with Arab American, with African American, with Latino and Hispanic communities, with Appalachian white communities. This idea is not a polarizing approach. It doesn't have to be. It can be about focusing on our collective humanity and recognizing that this is a legacy belief that has no place in the 21st century. And so almost all of the major civil rights organizations that we've been funding and working with for the last 8 years are definitely thinking in this way and moving in this way and standing up together. If someone's temple is bombed, they all stand up and recognize that's like bombing any of our churches. That's denying our freedom. So we do take an approach to this work that we have found is not polarizing and it is not divisive. In fact, it is calling forth our better selves, and we're feeling pretty good about that. But I would suggest the NAACP, the Urban League, the National Council of La Raza, the Asian American Pacific Islander Native Hawaiian Health Forum, almost all of the major civil rights organizations are moving, not just dealing with the symptoms, but with the underlying beliefs. And the implicit association test, you can Google that and take it. It comes out of Harvard University. There, everything is controversial to some degree, but it's a powerful experience to take it and to get in touch with your own patterns of responding and thinking, and then hold yourself accountable for questioning your automatic responses. And we're funding people who are working with over 50 police departments all over this country that are taking law enforcement officers through these same types of processes and deepening their understandings. So it is work that can be done. It doesn't have to be a Twitter storm that shuts down the conversation. It's real work. And the public health community, I believe, should play a lead role in getting that work done. Yes.
I guess the advantages of dismantling that type of thinking is clear, but my question is, what do you think is the incentive for people who would like to continue or perpetuate that type of thinking?
Well, I had to say to a friend of mine who was followed by a police officer recently, and he was angry and upset and all those things, and I had to say, don't let that momentary exposure to ignorance. So the incentive, I've come to the understanding that the incentive on an individual basis is ignorance. When we talk about collective and or group incentives for continuing to adhere to that belief system, I would call it arrested development. I think as this is about human development, and as we develop as human beings, we become more aware of our connection to other human beings, and we let go of those beliefs that divide us from one another. And so whether it's ignorance or a lack of development, and this is a developmental process. You don't wake up tomorrow and overcome racism. This is a process. So I attribute it to that. Now, there are financial incentives to keep things as they are, the status quo, and that's a different conversation. That's the structural piece, and that's where the mobilization and the work is required. It's not an either or in terms of how we do this. We have to continue to protest and to strategize and to legally attack those structures. But doing that alone will not heal this nation. We have to work on both changing the hearts and the minds, and as Mahatma Gandhi said, the souls of the people. Because otherwise we will have what we have today, which is, even though we had Brown versus the Board of Education and a Supreme Court decision to integrate the schools today are more segregated than they were then. And so it is a both and. But I don't think we've ever really had a concerted effort to uproot this belief system, to acknowledge it, and to say it has no place in our country. And I believe that's an important part of overcoming disparities, of creating healthy and safe communities, and indeed creating a culture of health. I think there was one final, yes.
This is on. You talked a little bit earlier about the public health community playing a leadership role in this effort, and you talked a little bit about the importance of the medical community as well. Could you talk a little bit more about what the public health community is doing and what their unique role is in this activity, and a little bit more about activities that are happening with the medical community? And I'm from the American Academy of Family Physicians, so just my sort of disclosure.
I bet you could tell me what's going on with that group.
No,
You
I
want to
don't.
tell us what's going on with them? No?
I know what I'm doing. But,
Okay, well, tell us what you're doing.
I mean, we're not involved in this, but I know that I have a specific interest in the issue of violence and trauma and how it impacts people across the lifespan. But I've only been working with the family physicians for 6 months, so
Okay. Well,
I haven't
thank
had a
you for
chance to do
sharing. Thank you.
much yet.
Yeah.
But
So-
I am interested in what organizations like ours and others can do.
So I didn't mean to make light of the life course perspective, because that is an important breakthrough concept that people are galvanizing around. And not only, childhood adversity, but also optimizing birth outcomes. So we've been very concerned about making sure that maternal health is ideal, if we can make it that way, and providing the supports, the psychological, emotional, and real tangible supports that minimize stress and the allostatic load during the pregnancy experience, and improving birth weights and birth outcomes. And not, we focus on infant mortality, but what we really need to be focusing on is optimal birth outcomes, so that we have ideal weights. And one of the ways that we can help in the very earliest phases of life is to really improve breastfeeding rates. There is so much that happens there that not only protects the child, but also protects the mother. I mean, I read an article from Europe recently where women who had breastfed exclusively actually had a decreased risk for retinal degeneration. Now, I'm trying to figure out what are the mechanisms, what are the pathways biologically that offer so much protection for both the mother and the child. But clearly, we do have some public health leadership. We have a real movement now to create baby-friendly hospitals all over this country as part of the obesity reduction effort. And if we could make sure that every child born really did get access to mother's milk exclusively, if we could just close the disparity gaps, that's a major component of mitigating the effects of adversity that they might be exposed to, of helping them to develop the social connection, the emotional resilience that is required in lives of adversity. So that's one area. This movement in our country now to increase access to early childhood development and early childhood education. This is, again, another important work. It's not public health work, which you asked, but it is public. It is the public's health work. And so making sure that whatever community you live in, and you do the opportunity mapping, and you ask yourselves, are the most vulnerable children getting access to these resources that are absolutely required for optimal development in the early phase of life? Making sure that our communities are safe. Now, there's a movement for safe communities and reducing violence and taking a public health approach to violence. I hope the public health community really steps up in that space, because that is, I think, where we are perhaps the most vulnerable as a nation. There is simply, and certainly the poor are the most vulnerable, because there's just too much killing and dying. That's another space where the other area where we don't have a good convergence, we have leadership in the public health community around the quality of housing and healthy homes, but we don't have leadership around an affordable housing policy and access to housing in neighborhoods of opportunity. So we need to rethink our nation's approach to housing as a factor in terms of health and well-being. And I think the public health community could do more there. And then finally, you know, this income inequality and this struggle for living wages, that is being led by many groups around the country. I don't see the health voice right there at that table in ways that it could be. But a living wage is a necessary component of a healthy life in our consumer-driven society. And so those are frontiers that are waiting for, I believe, the public health voice to be more organized and more present in partnership. Partnership is hard work, and that's the other challenge. But you're going to have an amazing panel come up and talk about these and other things, and we'll get more into the complexity of this work. Public health today is a very complex system. We spent the 20th century building it, and now the 21st century is asking us to, what's the term, to upgrade? 2.0 or 3.0 or something. But I think we will, and I think America requires that we do it. And so globally, that's the case as well. But I applaud the leadership of the American Public Health Association to put out that challenge that we would not only move up in our grade, but we could actually become the healthiest nation. We are the wealthiest at this point. Surely we could be the healthiest nation. Thank you.
Thank you, Dr. Christopher. That was really inspiring, and also I think gave us all a lot to think about. For the record, the American Public Health Association completely supports this concept in health and all policies. Our annual meeting this year has that as its theme, and we recognize that we are going to be working on things as a public health community that nobody thought of was public health just a few years ago, and that's the only way that we're going to make a difference in reaching our goal. It is now my distinct pleasure, again, with technology, to introduce you to the president of the American Public Health Association. Dr. Shriki Kumanika is the emeritus professor of epidemiology at the University of Pennsylvania School of Medicine. During her 15-year tenure at the Penn Medical faculty, she served as the associate dean for health promotion and disease prevention, was a founding director of Penn's multi-school Masters of Public Health program. At the same time, she held a secondary appointment in the Department of Pediatrics. Dr. Kumanika founded and chairs the African American Collaborative Obesity Research Network, a national network that seeks to improve the quantity, quality, and effective translation of research on weight issues in African American communities. She's also the vice chair of the Department of Health and Human Services Secretary's Advisory Committee on Health Promotion and Disease Prevention Objectives for 2020, is co-chair of the IOM's Committee on Childhood Obesity Prevention and of the International Obesity Task Force, and is a member of the World Health Organization's National Guidance Expert Advisory Group. She has extensive experience in advisory roles related to public health and nutrition policy in the US and abroad, and is currently a nutrition epidemiology advisor to WHO and the World Cancer Research Fund, and the co-chair and the Policy and Prevention Group of the World Obesity Federation. And it really is my pleasure to introduce our current president. Thank you.
The one with the face speaking. That makes sense. I come from a day when they wrote things out for you. They didn't give you little pictures to react to. Thank you for coming, and thank those of you who are participating through the internet for joining in. I should tell you that by signing on to this program, you've become a part of the social movement if you were not already. So this is, as I say, leave now if you don't want to be a part of the movement, because I think that we need all hands on deck, and we have a fantastic opportunity to really make a difference. I love this analogy of public health 2.0, upgrade. We need to really get into the next phase and do some transformative work to achieve our goal. So we're going to kick off the discussion about solutions with a very distinguished panel. You have the bios of the three panelists in your information that was distributed, so I would just highlight their affiliations and what they bring to this panel in terms of topic. And then they will each take 45 minutes to talk about their area of interest and the types of solutions that they're involved in. Then we'll start the panel discussion with maybe one question from each panelist, but please begin to write down your questions as we proceed so that we can have a dialogue at the end. So first we'll hear from Dr. Tom Farley. He is the CEO of an organization called the Public Good Projects, and you'll hear more about what that organization is from him. In brief, it's a media effort to improve the health of the nation. And many of you in public health, and not in public health actually, will know of Dr. Farley from his time between 2009 and 2014 when he was the health commissioner for New York City. And at that time, he really was involved in mass media campaigns. There were some very powerful, sometimes controversial media campaigns. One was Pouring on the Pounds about sugary drinks, and the other was 2 Drinks Ago, which was a campaign to reduce binge alcohol drinking. And they also had a lot of hard-hitting ads on the consequences of smoking. Following Dr. Farley, I'll introduce all the panelists at once. We'll hear from Dr. Linda Blount, who is the president and CEO of the Black Women's Health Imperative. I do have to say that at one time when it was called the National Black Women's Health Project, I was actually on that board of directors, and it is an organization for really improving the health of the Black community and working for reproductive and social justice for Black women across the lifespan. Dr. Blount, Ms. Blount, before she was in that position, was Vice President of Programmatic Impact for the United Way of Greater Atlanta, and she led a team focused on achieving transformation in health, income, education, and housing stability through place and population-based work. And she was also, prior to that, the first ever national president of health disparities at the American Cancer Society, where she was similarly responsible for strategic visioning and leadership to that society. And you can read the rest of these bios in your information. The third is Dr. Shoma Stout, who is the Executive External Lead for Health Improvement for the Institute for Healthcare Improvement. I will say that I first encountered Dr. Stout at a program that the Robert Wood Johnson Foundation had when they were honoring 10 people who had been selected from about 900 nominees as young health leaders. And this young woman got up when she was being recognized, and I thought after I heard her talking, she's going to transform the whole healthcare system single-handedly. She had her ideas, she had her strategy, and one of the criteria for this award is that you had to be under 40. So what Dr. Christopher said about youth are going to lead the movement, I think we represented well on this panel by Dr. Stout. She serves as the Executive External Lead, as I said, for Health Improvement. She's currently leading in that role a global initiative to improve the health and well-being of scale 100 million healthier lives. That's a campaign that you might have heard about. So she'll be talking to us about transforming the whole healthcare system and the implications of the Affordable Care Act and so forth. So without further ado, I'll turn the program over to Dr. Farley, and we'll hear about the public good projects.
Thanks very much. As Dr. Kuman-Yuka mentioned, I am the CEO of a new organization called the Public Good Projects. And we are beginning a new initiative that we are calling A Healthy America, which aims to use the power of the mass media and the techniques of marketing to try to address our nation's biggest health problems. In public health, we haven't used the power of the mass media much over the years, but to the extent that we've used it, for example, in addressing smoking with ads you see on television that encourage people to quit, to the extent we've used it like that, it's been not only effective, but also cost effective. And so we think this is very much an underused tool. It's a tool that could be used to address behavioral determinants of health. It's a tool that can be used to address policy determinants of health. It's a tool which can be addressed, focused on individuals. It's also a tool that can lay the groundwork and push policy change. So our initiative is about trying to harness those tools and with all the things that modern media can do to really tackle our biggest health problems in a big way. And we expect this will be we'll be in this work for decades. It's not something that's going to happen very quickly. But we're excited about that opportunity, and we're trying to get as many other people as excited about it as we are. That's all I'm going to say for now. I'll add more later.
Okay, great.
Okay. So good afternoon. I love that response. So thank you, Dr. Kuhlman, again. This is a great pleasure to be here. I have to echo Dr. Christopher's sentiment as well. This is really a lot of fun. I remarked when we were standing waiting to start that everybody looks so young. So that's great. I'm glad you all are here. So I am the president and CEO of the Black Women's Health Imperative, and we are an organization dedicated to the health and wellness of the nation's 20 million Black women and girls. We've been around a little more than 30 years, and we are the only national organization with this focus. After 30 years, there's still only one. So when I took the job about a year ago, a little more than a year ago, that surprised me, and in some respects sort of saddened me that there was only one. But it also made me realize, well, if there's only one, then we better do some serious work. And for the last 30 years or so, we actually have done some pretty serious work, and we've got our work cut out for us. So I'll just say, sort of by way of introduction, we're focused on chronic disease prevention, risk reduction. I'm sure you all know the chronic diseases we might be focused on. Sexual health and reproductive justice, and making sure that women have access to health insurance. But not only access, but understanding what it is, what to do with it, how to use it, and also the connection between health insurance and health stability and financial stability. So to that end, one of the initiatives that we're focused on is trying to look at what health means to Black women. When I first came on board, we did a quick poll to just ask Black women to define health. Just give us words and phrases, whatever this means to you. And I don't know, we collected several hundred words and phrases, and what we found was that about 80 to 85% of the words and phrases that Black women used to define health were psychosocial. I'm calm, I'm at peace, I don't have any worries. About 10% of the words were financial. I can pay my bills. I have enough money. I can take care of my family. Only about 5% of the words had anything to do with physical health. I'm strong, I'm healthy, I'm disease-free. So what that suggested to me was maybe two things. After 30 years since the Heckler Report of studying health disparities and researching and implementing programs and seeing that things are not better, in fact, in many instances worse 30 years hence, that maybe we've gone about this work differently or incorrectly, and that there's opportunities for change. But the other thought that occurred to me was that Black women were saying to me, if I can get my head right and my spirit right and my money right, I can take care of everything else. So to that extent, that's what we're focused on, helping Black women get their heads right, their spirits right, and their money right. And we'll take care of the health issues. And I think over the next few minutes or hour or so, you'll hear some interesting ideas from all of us about how we're going to make that happen. So thank you.
Sorry.
Hi, everybody. Welcome to Happy National Public Health Week. So You know, as I reflect on this conversation already today, and Dr. Christopher's comments in particular, you know, it brings me back to why we came together to create 100 Million Healthier Lives, whose purpose is to fundamentally transform the way in which everybody thinks and acts to improve health and well-being in the country. As a country, for better or for worse, we have a belief system that says that if we want to improve health, we need to improve health care. And believe me, as someone who is a part of the Institute for Healthcare Improvement and has spent the last 10 years working on improving the healthcare system in a safety net system like Cambridge Health Alliance, where 80% of people are in public insurance, where half of the people speak a language other than English as a primary language, I see the value that improving the healthcare system and improving effective access to things like primary care can give. But if you really sit and have the privilege of listening to people's stories, you know that it's exactly as Linda said, that what people need to be healthy goes far beyond that. And yet every time we think about how we're going to improve health, the vast majority of time, people tend to turn toward a solution within the walls of a healthcare system. Now, that's where a lot of resources are, so that's natural, but I think it goes beyond that. We've gotten used to the feel of that tool in our hand. You know, we know what it feels like, we understand how to use it, we feel a sense of confidence and competence in it. And so people keep using it over and over again, even though we know that at least in this country, when we look at the actual contribution to premature mortality, access to healthcare only represents 10% of the puzzle. And, you know, if you were building something and you had a choice of having a hammer or a screwdriver or a wrench and saws and other things, or just one tool, you wouldn't choose to just use one. You'd actually think, what are all the things that I could use to create something different? And I would suggest that if we want to create a healthiest nation 2030, if we want to raise the grade, if we want to build not a health care system, but a health system, we need to bring the tools together that health care, public health, community health, education, social sector agencies, and above all, people, families, communities have in tools to improve the health and well-being of each other, of themselves, and of the nation as a whole. And that's what 100 Million Healthier Lives is all about. It's about bringing people and communities and organizations together across sectors who have all committed and are holding ourselves accountable to an audacious goal. As part of getting to America's healthiest nation by 2030, we'd like to start by improving the health and well-being of 100 million people by 2020. Because at the end of the day, as is inscribed in the halls of the Institute for Healthcare Improvement, soon is not a time, some is not a number. So if we want to do something about it, what are we willing to hold ourselves accountable to do? Through unprecedented collaboration, holding ourselves accountable to wide-scale, innovative improvement that crosses across media, that brings people together across sectors, and helps us see data in a totally different way. And by changing system barriers such as policy, payment, and integration of data and stories so that we can actually begin to see the whole picture, we hope we can actually at least learn a tremendous amount on our way to helping 100 million people live healthier lives by 2020.
So now we get to hear a little bit more from each panelist in answer to a general question, and then we'll take the questions from you. I could start with you, Dr. Farley, and give you a chance to talk more about what role you think media can play. You know, why is this going to be different from what we've done before?
You know, increasingly we live in a mediated world, right? So we email somebody in the next cubicle, we spend all of our time looking at our smartphones, and we share videos with people, and that trend is going to only continue. And the words and images that we see all day long have a strong influence on us, much more so than we recognize. They influence what we think about. They influence how we think about them, influence what we do, and as a result of that, they influence the world around us. For example, if those words and images present smoking as something which is sophisticated and sexy, then we're all going to have a more positive view towards smoking, and people are going to be more likely to smoke. On the other hand, if those words and images present smoking as something which is disgusting and smelly and risky, then we're all going to be probably less likely to take up smoking and probably more willing to be supportive of policies that protect people from the marketing of cigarettes. So those words and images are very powerful, and in public health, as I said, we haven't used them much, but we have great potential to influence them. These days, anybody can put a video up on the web. We can participate in that national conversation with images as sophisticated as anyone else can, and we think that we should do that. We shouldn't complain about how the media is portraying whatever, gun violence, smoking, social determinants, if we're not participating in the conversation with all the tools of modern media. And so our interest is in changing that national conversation and using all the tools that we can to do that.
Thank you. So now we'll come back to Linda about what it will take to really move population health from the perspective of making sure that we don't widen the disparities. I'm sure that this is something that has been a part of your thinking, because as we go forward trying to save the general population, is it a concern that that Black women and other high-risk populations will be even farther behind?
Yeah, and that's a sort of for us been sort of a question for the ages. I'm sure everybody here has heard that technology is disparities producing, because some people have access to effective technology, I should say, not just all technology, but effective technology, because some people have access to it and some people don't. So if you don't have access to the latest in mammography or colorectal cancer screening or whatever it may be, then you don't get to take advantage of the life-saving properties that it has. So part of what we try to do is, of course, make sure that women know about what's available, but again, just knowing about it isn't good enough if you don't have access to it. So what we've embarked on, and actually we launched this back at APHA last year, something we're calling the Black Women's Health Index. So there's never been an index of Black women's health, and the basic premise that we've come at this from is the assumption that Black women are inherently strong and resilient and passionate about their health, and in fact not defined by disease and poverty and obesity and all the other negative stereotypes that you see. And so we've partnered with the authors of the Black Women's Health Study, which has 20 years of, I think it turns 20 this year, 20 years of data on 59,000 Black women to actually come up with a composite index of what it means to be healthy, what a healthy Black woman is. And if you think Dow Jones Index, cities and communities can actually index themselves against this index and measure the value of the investment in population health in their communities, maybe even, if we're lucky, to the zip code level. But I just want to echo something that Dr. Farley said. Part of what makes this interesting is, great, it's lovely to have an index, but we get to take the data from the study and crosswalk it with social media so we can actually understand what Black women are thinking about, what is meaningful to them about health and wellness, and marry that with analytics, actually create predictive profiles so that we can then implement programs and messages, particularly messaging that helps women understand what they can do, also gives us the ability to predict what might be most effective from a program perspective or messaging perspective to get women from one place to the next, to adopt one behavior over another, but also to work with policymakers to get them to understand what needs to happen. And those who know me know that I never shy away from shaming policymakers if it'll be effective. So it allows us to frame the issue of disparities reducing activities, and inequalities in general, so that the correct answer is either yes or because we don't like motherhood and apple pie. And so far, I haven't come across anyone who's willing to say that to me, at least not to my face. So part of what we have to do in understanding this and making sure that we don't make the matter or make the issues worse is help policymakers and the everyday woman understand what the implications are and ramifications are of technology, of the latest research, of new developments, so that she can make the best choice for her and policymakers can make the best choice for the nation's health.
Thank you. Very provocative. So, Shoma or Dr. Stout, I don't know if we're using first names or titles here, but so the healthcare system, in a way, has been talked about as something different from public health. We're competing for resources or attention or reputation. So you're going to bring those together. And if you could talk a little bit more about how that's going to work, it would be great to hear.
Well, that's a provocative question, I'd say. When I speak with anybody who's gone into healthcare, I have yet to meet a hospital CEO or even a CFO who gets up every morning to say, I am so excited this morning to be able to rob people in my community of the social determinants of health. I'm thrilled that women won't get access to housing or that disparities will increase because I am robbing the community of the resources it needs to be healthy. And I say that facetiously because I actually think some of the answer lies within that. When you actually go back to asking healthcare leaders their stories about why they went into this in the first place, and this is actually where we've started the conversation in 100 Million Healthier Lives, actually person by person, leader by leader, organization by organization, about what motivated you to do this work, what your story is. Universally, people went in because they wanted to improve the health and well-being of people and communities. And that actually provides a powerful common ground because they also realize that they're not achieving the outcome that they've spent often their entire lives doing, and yet are stewards of an infrastructure called, say, a hospital that may be creating 2,000 jobs in the community and feel responsible as employers to protect that, et cetera. And so when you invite people to go back to what they're in this for, when you align that with payment models that give them an option of walking in a different way and give them a support system to help people transition and start creating what we've been calling sort of low-hanging experiments around creating a continuum of health, you begin to get there. So I'll just give you a quick example, if that makes sense. I mean, some of it starts, I think, by just having a common piece that everybody agrees to. That could be smoking. It could be opiate abuse and substance abuse and its ramifications in the community. It could be violence. What we found is by bringing people together around something that everybody agrees to and where people see that they actually hold different parts of the solution, and that if they can create a flood the zone strategy. And I'll just give an example from around smoking cessation that was used in our communities, where the public health department, we agreed on a common goal. The public health department worked to enact smoke-free policies in restaurants and parks. The housing departments worked to create, actually we mapped all of the public patients to public housing units, and the healthcare system invested in peer-to-peer coaching and behavioral interventions and access to smoking cessation products. Primary care made smoking a vital sign and integrated health coaching into every single visit. And the hospital facilities went smoke-free and engaged employers across the community to be able to do something. Then it suddenly became, instead of everybody sort of trying to lift a boulder up a hill, at one point, then another point, and another point, it was like we were all moving together. And suddenly people quickly realized how much more powerful those solutions are. And it also creates an opportunity to do something that I think is quite critical, which is actually to build relationships and help people understand the different kinds of the different pieces of the puzzle that other people hold. I think this is a powerful moment in the context of the Affordable Care Act, in that I think healthcare is more ready than it ever has been to actually begin to partner with public health. And I have to tell you, some people are afraid that having come late to the party of actually realizing that there are all these other factors, that people won't necessarily be accepted, or even that the desire to help will perhaps not be trusted. And we can understand why that would be. There's been history there. And yet, I think that the only way you begin to start developing collaboration is by building relationships, by trying it out, by acknowledging that there needs to be safe space for people to mess up and to, at the same time, have the relationships to work together and correct. It's, I think, one of the reasons that we're incredibly excited to be partnering with Healthiest Nation 2030 and 100 Million, so that we can begin to intentionally signal that in Healthcare 2.0 and Public Health 2.0, to adopt Dr. Christopher's words, this has to be a partnership where we're all working together for the health of the public.
Thanks. If any of the others have thought of things they wanted to say to add before we go to out for questions, feel free. If not, we can come back later if people are itching to hear what you have to say. Right? Okay. So it's your turn. Okay. Yes. We have mics coming.
Good afternoon. Directed more to you, Mrs. Blunt. Women make 77 cents per every dollar that men make, as well as African American women make 64 cents for every dollar white men make. How can we close these wage gaps while also improving our healthcare system for these women?
Yeah, that's a great question. So, I think the short answer, which you've heard already today, is value. Not only are women less valued in the society, but black women are, I think it's fair to say, the least valued in the society. This is one of these questions that's going to take everybody, as you heard earlier, to deal with. But part of this, and I think what's sort of fundamental, is this notion of denial. More than 10 years ago, when I was at the American Cancer Society, we did a survey, and at the time, I think it was 50% of Americans didn't believe health disparities existed, or that race or racism had anything to do with health outcomes. So I recently read another study where now up to 65% of Americans don't believe health disparities exist, and that racism plays no part in any of the inequalities. And I think, this won't come as a surprise to anybody in the room. We tend to view poverty as a character flaw. So Sam Broder, who was at NCI years and years ago, said poverty is a carcinogen. It's a hypertensive, it's a depressive, it's a lot of things. It is not a character flaw. So until we can help our brothers who run major corporations understand the value that women bring, I think this continues. But I'm hopeful because of all that we've seen around equal pay and the Women's Fairness Act and all the policies that we hear talked about, but also what you see on the ground, that we're beginning to make this point. And I go back to, even for corporate leaders, teeing up the issue as, do you want your company to stay in business, or do you want to be against motherhood and apple pie? And I think we'll see this happen. It's going to take a while. Hopefully it'll happen in our lifetime. But we're seeing some signs that at least people are waking up. You've seen what's happening with wages among some major corporations, that people realize they can still make a lot of money and pay a fair wage.
Thank you.
Albert Trillian. And first I want to congratulate you, Dr. Farley, on taking this next step in your career. You mentioned some past campaigns, I think, from the CDC. The one with Terry and smoking cessation is very, very impressive. I'm wondering what other issues your company is going to look at related to public health and how sensitive you're going to be around some that are more volatile, or if you're going to go after those as well. And I'm thinking specifically around the issue of gun violence. I also think about, I don't see controversy there, but some people do around immunizations. I think Ebola was mentioned, but flu vaccinations are very important. I'm wondering what other issues you're going to be looking at with your new company.
Yeah, good question. We're trying to prioritize our work around those things which are going to have the greatest impact on health in America. And if you look at the statistics on risk factors, they'll lay out some behavioral determinants. And to me, the top four are smoking, unhealthy diet, physical inactivity, and excess alcohol consumption. Alcohol is something which doesn't get nearly enough attention from my perspective. And so I hope that we're going to be addressing all of those. I would imagine we're going to get beyond those, but I think those are immediately what is on my frame of mind. And we addressed a lot of those when I was in New York City. So we had a media campaign on alcohol. We had a media campaign on physical activity, which wasn't terribly successful, but at least it was a first try. And we did a lot on smoking. And then we worked on sugary drinks. So there's precedent for working on all of those. I should also add, though, that media to me is not just about addressing an individual consumer who sees an ad. It's also about changing a social norm, which then can deal with, lay the groundwork for policy change. And so I think mass media can also lay the groundwork for focus on social determinants, and should. That's harder for me to figure out exactly what we're going to do, but that's something that I hope we're going to be getting into as well. At the end, media is not an intervention in itself. It's a way of changing the national conversation that then leads to changes on the ground, which ultimately promote health. And so where we think we can make the biggest change, that's where we'll be.
Is a question here? Right. I think they want you to wait for the mic so the people on the web can also hear you.
So I'm with the Metropolitan Washington Public Health Association Disparities Committee, and we've been very active in the last couple of decades, I guess, on different issues. But more recently, we've become involved in the mass incarceration issue and how to tell the story to overcome some of the racism embedded in the war on drugs and the struggles of people to get jobs now and housing. And I was a physician. I just retired about a month ago, and for many, many years, I never really understood all the time why people didn't have jobs when they came in to see me. And gradually, I realized that many of these folks had been in jail and were having a lot of trouble getting jobs or housing and so forth. And I think that it would be very interesting, both in terms of how the media could address this question, and also how medical education and any of the organizations could tell the story in a way that would not be so much blaming everybody for being in jail, would note that many of the drugs that put them in jail in the first place are now becoming legalized or becoming less offensive to people, and figure out how to tell this story in a way that's good. We circulated a petition against Metro, which is the transit system in D.C. and suburbs, for stopping 2 years ago to hire people who had a record. And this is a vicious policy they have, by the way, and I have some flyers on that if you're interested. But in the process, we tried to figure out how to talk to people across the city about this issue. And so I'm interested if you have any ideas about how we can do that, and to recognize the fact that mass incarceration not only hurts the individual who's in jail, but the community and many of the women who serve them, relate to them.
There was actually a fantastic keynote that Don Berwick did in December, which I think may be available on YouTube now, where he talks about from the story of a particular youth who was incarcerated and what would need to happen for him to transition back into the community, and just makes utterly clear that for Jose there is no option except to go back. It was by far the easiest thing to do, is to actually be in prison. It was much harder to raise the $500 to get a driver's license, to not have a place to go, to have a difficult time getting a job, all of the barriers that occur once you've been incarcerated. And there are actually amazing programs like UTEC that are reducing the recidivism rate by 75%. And what it takes to do that is also known. There are actually bright spots about about breaking the cycle of racism, incarceration, and poverty, and re-incarceration. And yet, most of these solutions actually aren't scaled up or available across communities. And so one of the things we're trying to do is figure out how we can take those kinds of bright spots and not only help create messages that everyone can be aware of so that they can have an understanding of the issues at the level of the person that's going through that process, but also have a way of sourcing systemic solutions that can be adopted across communities.
Thanks. You want to comment on that as well, please?
Very briefly, I mean, you know, I have to agree with everything you said. There's an interesting book out. I think her name is Jill Leovy. It's called Ghetto Side. And she was a reporter embedded with the LA Gang Crimes Unit. She talks about, you know, the life of the police officers. But what was interesting is the opening line in the review in the New York Times said black men are 6% of the population and 40% of the murders. And so from, you know, if I'm an economist, and I'm not, but I think there ought to be some field of epidemiologic economy, or an economist who's also an epidemiologist. I would love to do that. Just knowing what I know about as being an epidemiologist gives me this much, but I'd love to be an economist too. But you can see the overall negative economic impact of this incarceration policy that we have here. Because if you could get men out and get them jobs, then they don't actually go back. And that has been established time and time again. But what we get is this constant cycle, and then you see it play out in disease in terms of HIV and its concentration in urban centers. So there's every reason and every economic benefit to break this cycle, to take the kinds of programs that Tom was talking about and scale them and replicate them. But then we have to look at this perverse incentive for why that doesn't happen. And that's where we need to hear more voices speak out against that.
I'm going to take the prerogative of the chair and just mention something that the thread that I hear coming through these talks. I think it's very instructive that all of our questions about how to make America healthy have been on social determinants. You know, we've had a couple of questions on economics. The economics gets into what businesses do. We've talked about the relationships between these different issues and how to get to the root causes. I mean, alcohol, for example, is underneath a lot of the other social issues. So, you know, one question is, how does public health leverage the forces necessary to address these problems? It, you know, could make you feel powerless if you thought, well, who's in control of the justice system and how do we get in there? I mean, it turns out that one of our members and who's been on the board of directors and so forth is now at the Justice Department, you know. And so how are we getting into the places of power where these things are controlled? And if one sort of idea in response to the last question, the Fresh Food Financing Initiative, which is the program to get grocery stores to open up in underserved neighborhoods, has a specific element in a lot of communities about hiring ex-offenders, because the communities who getting these grocery stores insist that that be a part of it. That if you're going to bring a lot of jobs into the community and bring money into the community, you've got to give some jobs to the people who can't get jobs. And at least in Philadelphia, where I'm from, there are businessmen who are quite proud of their ability to work with these programs. And so I think looking at different types of connections and finding out, you know, who's making jobs, you know, to deconstruct the system into specific places where you can go and say, how many ex-offenders did you hire? What's keeping you from hiring ex-offenders? I mean, I think we have to think as creatively as possible about influencing things over which we have no direct power. And I'd love to hear some comments or questions about, you know, other success stories perhaps in breaking through some of those areas so that we're not only sitting feeling we're on the outside while other people are controlling the health of the population. So we can continue to take questions, but I wanted to throw that out there because it's a theme that's coming through here about things that we don't have any direct control of. How do we actually make them change?
I have a different question. My question is, and I don't know to what extent, but there's a kind of massive reorganization that's going in the hospital system, basically increasing the bottom line at the expense of patient care. My wife is a nurse, and I was in Michigan on Thursday speaking to my niece who is working for a very respectable hospital system in Michigan. They are changing the whole system from 6 patients to 8 patients, and at one time she had 12 patients. So this question is for Dr. Stout. So how, and I don't know to what extent this is nationwide, but how will this undermine your effort? And I don't know if this is a response to Obamacare, or I really don't know much to comment on that.
Thank you for that question. I think it's a really critical one. I think there are many forces that are acting upon healthcare to create to change it. Some for the good, and some for the not so good in terms of the health of the nation. The force to make American healthcare a business is unlike anything that I've seen in any other country. And I've had a pleasure of traveling to or working with over 20 now. In almost every other country, healthcare is seen as a service. And here we see it as a business that needs to be optimized. And that, while it can bring strength and financial rigor and accountability, it has real challenges as well in terms of thinking about what the goal or outcome is, which is the health of people. I think one of the major forces that's helping to sort of shape and align the business incentive with the health of the nation is that within the Affordable Care Act, everybody thinks of that as an access act to improve access to health insurance. In fact, a huge part of the Affordable Care Act is about creating something called changing payment models so that healthcare is paid not just for the unit of service that's delivered, but rather for caring for a person over the course of time. There are many people who say it needs to get better, et cetera, but there are mechanisms to innovate so that people are actually paid to keep people healthy. The system that I had the pleasure of being a part of it in Cambridge, we had Massachusetts healthcare reform several years before the federal healthcare reform. And what we saw is that actually suddenly there was a need and a desire and a hunger to switch payment from fee-for-service, where you're just paid for the person you're seeing or the thing you're doing, to global payments. And in fact, we flipped our financing model to about 40% and then 60% global payments today. And as you do that, you quickly begin to think, well, who in our system isn't doing well? Who costs a lot, right? And when you look at who costs a lot, you immediately uncover everything we've been talking about, that it's the social and behavioral determinants of health that are creating cost. And what happens is something very funny. Before that, you just didn't see it, right? Because it was a simple transaction. Someone came in, they needed a service, you provided that service. But when you suddenly see everything that's going on with a person that's leading to them to have poor health outcomes and high cost, suddenly you have a natural sort of pull to try to figure out something that we've been calling the AAA, of improving the experience of health and well-being for the person, to improve the health of the population, and to reduce the cost simultaneously. We believe these are not conflicting priorities, that you can actually create a health system that achieves all of those. And in fact, what we've been able to do at Cambridge Health Alliance is lower the cost of care by as much as 10%, absolute, and to reinvest those savings into the helping support people in the social and behavioral determinants of health. And when I had the pleasure of speaking with all of my colleagues who are leading transformation across the country, everyone had gotten to that point. And when you know that the Centers for Medicare and Medicaid Services federally are actually pulling the entire country toward global payments, suddenly you see the opportunity in the next 5 years, not to have to hit people over the head with the truth, but to help people come to a natural aha moment. That as you look at what creates cost, it's not the medical determinants by and large, it's the social and behavioral determinants. And that creates opportunity for alignment.
So let me just clarify. You're saying that in answer to the question about this, optimizing the business, that if the Affordable Care Act applies to all hospitals, I mean, there's no such thing as a hospital that would be exempt from the Affordable Care Act, then would they be held responsible for the outcomes?
Well, yes and no. Interestingly, there are hospitals that have great outcomes but refuse to accept Medicare or Medicaid, our public good. So when you think about disparities and access, it's a whole different kind of disparity. And their outcomes look great because they've excluded the poor, they've excluded people with mental health issues. And it's I think a different kind of thing that we need to think about. It's also true that there's commercial insurance. And so part of what's needed is actually wholesale agreement among payers to try to shift to a different model. But payers are actually quite willing to do that, and many are willing to begin to innovate and are already moving that way.
That's helpful. So we know what some of the devil's in the details of this, right? So.
I had a question. I'm a first-generation American, and I wanted to know what your, studies show that it only takes one generation for health outcomes to become worse. So I wanted to know what your organizations are doing to reach out to new Americans, to immigrants who come to this country with really good, decent health, and then like a couple generations later, they're not as good.
Answer to that. Yeah. Yes.
So the Black Women's Health Imperative actually has had a number of projects historically outside the country, some countries in Africa and also in the Caribbean, partly to try to understand that. We don't currently work outside the U.S., but we take care of, all women. And you're right. I mean, the longer you're in this country, the worse off you are. But one of the ways that we're hoping and are addressing this, but hoping to do more, is to be really respectful and mindful of the cultural traditions of the women we serve. We cannot treat all Black women like they're just Black women, because there's no monolithic Black woman. So part of what we've done in places like Chicago and Los Angeles, because we're across the country, is to encourage that dialogue, get women to share their stories. What have you learned from your mother and your grandmother that you still do today that works, that helps keep you emotionally stable, physically healthy, financially healthy, that sort of mother wit. And so, our work is designed to make health easy. I say we want to put it in the way. We want women to trip over health everywhere they go, whether it's emotional health, financial health, physical health. I want women to say, here it is again. One more opportunity to be healthy and do something healthy. And part of that is not is honoring the traditions that they come from and listening to what our mothers and grandmothers have said to us forever that we chose to ignore in many cases, but now are coming back, that we can share with each other. So that's part of what we're doing, and we're encouraging women, because we are social animals, do things together. Whatever it is, whether you go eat or work out or shop or, plan for college education for your kids, talk to each other, mind each other's business, get involved, feel connected. I think Dr. Christopher talked about that. If we can feel connected not only to each other, but to our past, that will go a long way to help us stay healthy.
I just wanted to follow up, because I think this is an interesting issue that we haven't explored too much. Are the youth in communities, first generation, second generation, are they more vulnerable? Have you done any work with youth to see if there's a particular vulnerability to taking on risk when people, when women move to this country and then the children want to be more like, American or whatever.
It's interesting that the youth who come to the country actually are more resilient, less likely to fall into kind of what we see the media portrayal, especially of black women. I mean, we've seen the Real Housewives and everybody else, and I don't know a soul who actually acts like that. But obviously, if your parents are immigrants but you're born here, you grow up differently than your parents, and so you're a little further removed from the tradition that your parents and grandparents have. So those kids, less susceptible than sort of African Americans who've been here for generations, but more susceptible than those who come from to the country.
I think Asian youth have been shown to have actually much higher levels of mental health challenges in many communities who are first generation, just because the expectations of how parents speak with and think about the way in which they communicate with their youth, and often the way that parents got there, which was through a system where the only way you could get out of poverty is through education. And so everything was about that, which is very different than the messages that we sometimes send as a society, that can create a lot of conflict as well.
So we have to bring those youth along with us in the movement and find some leadership there too as well. Thank you.
My name's Mary Tierney. I'm a pediatrician, and been working with the American Academy of Pediatrics on a whole variety of issues, including gun violence. I also ran a Medicaid program for the United States at what is now CMS. So you kind of got me into this. What are we doing for the young people? And by that I mean birth to 21. And to get this resilience, and how can we collaborate together? Just one quick statement. American Academy of Pediatrics in Bright Futures was funded by HRSA and is in the Affordable Care Act, talked about that the only safe gun in a house with children and youth is no gun. Got sued by the governor of Florida said that physicians were no longer allowed to talk about gun violence and gun safety. We sued, and then won, and then it got overturned by a higher court. So I guess I'm just asking all of you, what are we doing for the young people? Let's start talking to them when they're infants.
Thanks. So who has answers to that?
Well, go ahead. So I practice, I'm an internist and a pediatrician. I practice in a community that there's an incredibly high rate of gun violence. And fortunately, we don't live in Florida, so we can talk with people about that. But it seems to me that the problem starts much earlier than that. And I actually wonder about solutions. The cycle of addiction and violence in particular is incredibly prevalent. And breaking that cycle, it's not enough to just talk with people in a 30-minute visit, even several times a year. It requires a systemic solution beyond that. And I think programs like Cure Violence, which have taken and applied public health principles to thinking about who might be at risk of an angry outburst, so the use of violence interrupters, taking sort of a model that was used to interrupt the transmission of tuberculosis and applying it to interrupt the cycle of violence, I think are incredibly promising kinds of approaches that, if supported in addition to that with messages from the healthcare community and public health, show great promise. They've been shown to reduce gunshot violence by 50 to 75% in over 20 communities already. I'd love to see those scaled.
Let me just jump in here, and I am a big supporter of those programs, but also just to point out that gun restriction works. In New York City, we surveyed and found about 2 or 3% of households own guns. and the nation as a whole, it's about 30%. And as a result, in New York City, we have very few shootings relative to other cities. And our gun suicide rate in New York City is 1/10 the national average, which makes our overall suicide rate about 1/2 the national average. So if you don't have guns around, guns don't shoot people. And I know the conversation in this country has gone in the opposite direction for the last 20 or 30 years. But I hope that as a public health community, we can really say that often enough and push the agenda back and say, we don't need to have so many guns. And if we don't have so many, then not so many people, particularly young black men, are going to get shot.
So you can't stop there, because now you put yourself on the spot. So you have the public good projects and the media company and all the talents of marketers. So you were challenged earlier about whether you would be taking on issues like that. And my question is would it be possible for the public good projects to take on projects? You were talking about where you've seen the impact, but changing norms, maybe not at the same level, but could you see yourself really branching out to help with the marketing expertise of changing norms on some of these difficult issues?
I would love to take on gun violence with in media messaging and see if we could push a policy agenda. Exactly how I do it, I don't know, but I would love to do that.
Okay, it's on the record.
Yeah, this is for Dr. Stout. You just said something really interesting. You mentioned techniques for preventing tuberculosis transmission used in the context of gun violence. Could you explain that intervention in more detail?
Sure. This was a technique that was pioneered by Dr. Gary Slutkin, who was an infectious disease physician who worked in Somalia in refugee camps on tuberculosis and then HIV with the World Health Organization. Came back to Chicago thinking that he was going to get away from all of that. And it looked beautiful at first, and then realized that there was another epidemic that was happening in his neighborhood called violence. And as he looked at how people were treating and responding to violence, thinking of it only as something where people got locked up, and that was a treatment, it reminded him about how with tuberculosis, people used to put people in sanitariums, and that was sort of the way that it was treated before modern public health principles came to bear. And so he began to look at the graphs and noticed that there were similarities and began to wonder, what if instead of thinking of violence as only a social issue, which we all know it is, what if you could actually take some of those same principles to bring to bear, to think of it as a disease, as an infectious disease? Would that bear? And what he did was say, well, if you think about someone who is likely to somebody has violence perpetrated against them in some way, or becomes angry and isn't able to cope and to sort of mitigate regulate their emotions, they're more likely to perpetrate against someone else, and that actually continues a cycle of increasing anger and violence. And so he created a new group of worker called a violence interrupter, who are people from the community who are skilled at relationships, are able to identify usually predominantly young men who may be who seem like they're just about to explode. And instead of doing that, to actually talk with them, befriend them, and help de-escalate the situation, and then put them in what they would call treatment over time, which is about anger management and other supportive services. Similarly, they then go and find all of the people very systematically that person interacted with, who may have also caught the epidemic of anger and violence, and to begin to start working with those people as well. And then they do broad-based community engagement of families that actually together mark things like 38 days since the last gunshot here, 50 days since the last gunshot wound, and talk about what they'll do instead with parks that are able to be used again for children to play in, which previously were places that were high trauma areas. And so it's a powerful program and a powerful model, not the only model. There are others out there, but I think that's the opportunity when we begin to really start working across sectors, to begin to think, how does something that works here, could it apply somewhere else if we think about it in a slightly different way?
And just wanted to touch on Thomas' point, yes, I believe the only safe gun is no gun. But we really, from a systems perspective, and we in public health talk about this all the time, we've got to get at root cause. Why is there this anger? Why is there this frustration? Guns become the expression of it, but why does it exist in the first place? So clearly, and we've seen this if you do global health work, you see it all the time. If there are jobs, if people are valued, if we could end poverty, if we could end racism, if we could end any number of other isms, we actually wouldn't see this. And short of, sort of adopting a police state, I mean, that's not the look that we want at all. There are solutions, but they're systemic solutions, and they first require valuing people. One issue in New York is to be lauded. I mean, you have to assume if it can happen in New York, it can happen anywhere. So why hasn't it happened? And you have to look at the sort of the prison industrial complex. There's a lot of money there. And so until we interrupt that cycle, then I think we continue to see this.
How many mics do we have, just to make sure everybody who wants one gets one? Okay, please. We have enough time for, I think, all of your questions.
Okay. Good afternoon. Dr. Farley, my question is directed towards you. Firstly, I think it's a wonderful and innovative idea for you to use the media to address the various health issues that the country, but better, there we go. It's wonderful that you're using the media to influence our actions and ideas and so forth to address the various health problems that the country has. You spoke about alcohol, obesity, and now gun violence. But do you have any ideas, or do you think it's possible to address the issues of racism that Dr. Christopher mentioned earlier? Using the media, of course.
I mean, I'm not sure that I have a good answer to that. Let me just say that, but I do think much of our views of the world come from the media. The things that we think of as our individual thoughts, they really do arrive to us through images and words that we see. And so many of our social problems and social determinants, because that ought to be influenceable if we could change the media narrative around those. How to change that around race and racism, I don't know, but I would, and if I knew, I would be enthusiastic about solving that, but I certainly, we want to engage in that conversation, let's put it that way, and to the extent that we can be part of solving that problem, I would be enthusiastic.
Hi, my question is for Ms. Blount. I wanted to follow up on what you said about the survey that you, or that your organization put to Black women, and one of the highest things that you've received was about psychosocial issues, and I wanted to know what initiatives the Black Women's Health Imperative are doing around mental health and making sure that Black women are accessing mental health. I think a lot of times, well, speaking personally as a Black woman, you don't feel that maybe mental health is in the formal sense, or the establishment isn't some place where you can go or they'll really understand what you're going through. So I guess, could you speak more to what your organization is doing around that?
Sure. And you're right. I've got a good friend who's a psychotherapist, and she treats mostly Black women. And she said Black women, her patients tell her that they can be depressed between 11 p.m. and 6 a.m. And after that, they've got no time. Just can't fit it into the schedule. And culturally, there are, we are reluctant to admit that, these are issues. So what we're doing is a part of our wellness program, which is it's called Grab Your Girls and Go, because we are social animals and women like to do things together, is to implement something that's called 7 and 7. So it's, what can you do in 7 minutes, or what 7 things can you do that are easy, that don't require you to go do anything extraordinary, so that we can put this in the hands of the everyday woman. And what we've discovered is the benefit of 7 minutes of meditation, and you can do that anywhere. The benefit of talking about whatever is happening in your life stressors. We give women different language to use. You don't, depression is a diagnosis, so you don't say, I'm depressed. We encourage women to talk about what it is they're feeling, to acknowledge what's happening in the workplace. I mean, what we've seen, in terms of talking about the connection between mental health and physical health, Black college-educated professional women have higher rates of low birth weight babies and maternal mortality than white women without a high school diploma. And a lot of that is stress. We don't know the complete reason, but a lot of it is stress. So we're encouraging women to talk about it and then providing them resources in the various cities around where we do our work to get help, to seek help, whether it's, maybe it's a spiritual help, maybe it's going to see a psychotherapist. We're not dictating what it is, but we're showing them that this actually impacts their physical health, their family's health, and that they owe it to themselves to speak about it, acknowledge it, and get help.
Okay, so this is for Mr. Farley. Obviously, obesity is a huge issue in our society, but I feel like pressures from the media also to be a particular image could also lead to negative public health issues such as eating disorders. So what are ways that through the media you can prevent these negative issues?
Yeah, we live in a society that where there's heavy marketing of food, and so as a result of that, an awful lot of people are overweight, and then there's marketing of images to make you feel guilty about that, and that really makes a lot of people suffer. Our focus when I was in New York City was addressing the food marketing, and so our targets were never people who were overweight. Our targets were sugary drinks, and so that's what was depicted. I think we can address the obesity epidemic that way, and at least put the attention where it ought to be rather than putting the attention on a person who I view as a victim. It is tough, though. I don't know that we have a way to control sort of the projection of the ideal body image out there, and there's a huge industry around that itself that's hard to counteract. So at least if we can draw people's attention to what is the real problem, which is the marketing of foods which tend to make people obese, then we can get closer to a solution to that problem.
Yes.
We've talked a lot about a variety of different problems and solutions and social determinants of health, all of which I think are things that we should also get excited about. But as advocates for public health, one of the greatest challenges that I've seen over the last couple of years are efforts to undermine the science that underpin the work that we're doing. So I'm curious if any of the organizations up there are doing anything to actually counteract the skepticism regarding science that impacts immunizations, that of course impact sort of even the acceptance that gun violence is a public health issue. If the answer is no, that's fine, but as an advocate, it certainly seems like that's also an important thing to work on as well.
To answer on behalf of APHA, no?
The American Public Health Association. So we have tried to find our allies where we can, recognizing that there are certain people we're not going to be able to get through. And for some of this, we try and make the science so accessible that the people who are hearing it are hearing the counter piece. So if perhaps a member of Congress is talking about vaccines, what we try and do is put information out that is very basic, very clear, and makes the lack of connection between vaccine and things like autism indisputable. There are some things we're never going to be able to achieve. And there are some people who will hide behind the lack of science or the fact that they're not scientists as a way to kind of bypass that issue. But where we can, we are putting things forward that are as accessible to the public as possible. And with that, I would like to say that we are really, I know that there's one more question back there.
Yeah, I have
and
one
then
quick
after
question.
that, we are out of time.
Actually, I have a quick two-part question. For the Black Women Imperative, I see the whole theory of the strong Black woman as a barrier to healthcare, and I also see the Black church sometimes as a barrier to women receiving the healthcare, whether it's mental health, even treatment for diabetes, that prayer is supposed to replace that. What are you doing to attack those particular things, the strong black women theory and the relationship with the black church?
Okay. So, and that's a great question. Part of what we're doing with the Black Women's Health Study data is actually to try to clarify and debunk that myth, because that has harmed us more than it has helped us. And we actually have a partnership with the faith-based community to help pastors debunk that myth among women and talk about behavioral health and mental health and encourage their congregation to seek services and to destigmatize it and put it in spiritual terms, that there is absolutely no shame in seeking out mental health services just like you would physical health services or financial health services.
Thank you. So I'd like to thank the panelists for helping us to start what I hope is an ongoing conversation through the various media, and sharing your own experiences and commitments in these areas. So I hope you found something in this discussion you could connect with, and we'll keep following it. And I'd like to turn this over to Susan to make the closing remarks.
Please join me in thanking our panel. Thank you so much all for coming, for participating, for watching via the web. I don't know if people have been following, but Twitter has been lighting up, so we really appreciate that. I think this really is the beginning of the conversation. It's a kickoff to National Public Health Week, but it's a kickoff to a 15-year project to really help create the healthiest nation. So we are excited to partner with each and every one of you, and we have started that with a couple of you, and we will continue to do that. And there is food out there. Please continue that conversation at a reception at our, and again, happy National Public Health Week, and enjoy.